how to go about ultrasound guided management of a cesarean scar pregnancy. Handing over to you, sir.
Yeah, thank you so much, Mansi. And wonderful talk by Swati madam. This is how, we teach our student that, this is the disease, this is how, it develop, and these are the outcomes, and these are the optional management, which depending upon your skills, depending upon your circumstances, depending upon the team you have, the system where you're working, you can approach. See, in textbook, in literature, everything is described. Everything is described, and all of us have faced, most of these situations. How we are going to manage. When Dr. Swati was planning this webinar, I've done many laparoscopic and then hysteroscopic, and then gradually moved to my USG guided as well. And then I've discussed with other people as people have done a big number of cases in ectopic pregnancy, including the scar ectopic, and the number they've managed is medically, in the sense what they've done is ultrasound guided, injection of KCl to stop the cardiac activity, and the methotrexate to destroy all these decidual tissue and trophoblastic tissues. And as Indu madam has said, these medical management or this systemic methotrexate, in the sense intralesional one, is going to take a lot of time, and you need to counsel these patients way back beforehand that it can take up to 3 months to 2 years to resolve. Some residual tissues, some ultrasonographic signs will be visible. Beta ECG may be gradually declining and becoming negative. So pre-operative counseling, where whatever treatment modality is you are taking, is important, especially when you are managing it medically, USG guided, hysteroscopically, as well as other than laparoscopy. Laparoscopy repair, treat you there and there only, but it is good for type 3, type 4, where the bulge is visible externally. When the bulge is not visible, it's very difficult to exactly find where is the scar and where the pregnancy is growing. So taking a case where there is no exophatic component laparoscopically may land you in a problematic situation. So ultimately, the treatment is decided by a good ultrasound. This is what I am emphasizing. See, whatever we have discussed, the classification is all depending upon your diagnostic modality, which is ultrasound in most of cases. MRI is not required, as we have got a good sonologist all around. So I'm starting my presentation. Let me share. Yeah. So Swati madam has nicely covered all the aspects. So I'll be skipping all. Presentation is visible? Yes.
Yes, it's visible.
Thank you, ma'am. So USG guided management of scar ectopic. Niche, we all know, is a defect in the myometrium. It has got its own gynecological problem, infertility related problem, and pregnancy related problem. In the pregnancy related problems, in the third trimester, accreta and creta percreta, and in early trimesters, cesarean scar pregnancies, which is basically nothing but pregnancy, which is ectopic one, embedded into the myometrium. At the site of previous scar, ultrasound criteria, madam has nicely described that empty upper compartment, empty cervical canal, G-sac located in the patient, having a history of previous cesarean section. We all have seen cases where myomectomy was also done, and the pregnancy was implanted at the site of myometrial scar, and these are interstitial pregnancy. Again, the management is laparotomy, laparoscopy, or medically, all these options for myomectomy scar. But for cesarean scar pregnancy, earlier the diagnosis, better is the outcome. Why I said this thing? Because if the pregnancy is very small, you can manage it nicely without much complication. When the pregnancy is growing in the means of gestational age, the vascularity increases, there's hardly any myometrium, there is all scarred areas, and you are likely to land up in the problem, which are because of scar ectopic pregnancy. And these are grade 1, 2, 3, and 4. So these are the ones which are exophatic. See, it is your radiologist who's going to tell you that your pregnancy is growing into the abdominal cavity. It is exophatic one, and there's no role of hysteroscopy and USG guided in such scar because they are very thin one, going to make you more problematic one. So laparoscopy is the solution. But yes, what is ultrasound guided evacuation? So one thing is very sure that it should not be exophatic one. The second thing is, what is that exophatic? Can you see this ultrasound picture? This is a uterus where the pregnancy is growing at the site of previous Caesarean scar. Component is in one of the myometrium and partly is in the endometrial cavity. And one thing is sure that it is not going into the towards the bladder or towards the abdominal cavity. So these are the one. Now this is a live cardiac activity patient, 7 plus more than 7 weeks of pregnancy, which I'll be showing you how you manage it ultrasound guided. Of course, Ajay is going to discuss hysteroscopic. There are n number of modalities. We all need to know how we are managing. I'm going to discuss the surgical aspect, the technical aspect of such modality. Now you can see that this is a pregnancy which is there. This is a video. Ultrasound. Am I audible clearly, madam?
Yes, you are audible.
Hello.
Audible, Dr. Frank. Yeah. And we can see the video.
You can see the video, but my voice is coming clearly, madam?
It's clear, very clear.
Yeah, fine. So I'm just reducing its voice. So this is a video where, I'm using USG guided in the operation theater, gradual dilatation of the cervical canal so that I will not be going towards this side. My cursor is visible? Yes. So here I'm gradually dilating. You can see a fetus which is just moving because of the dilated trauma. And once you have dilated decently, then I'm going to use a suction. Now this is a suction cannula which has come in the cavity. And gradually I'm very controlled way. I'm just opening the suction. I'll be showing you how I'm controlling this suction. There are foot control suctions are available, and there are manually. If you do not have, you can just bend the pipe slightly, and by which you can control your suction, how much suction you're going to give. And gradually under ultrasound guided. Why I said, because you are not perforating, you're not moving towards the other side, and gradually are sucking all these components. You will be seeing, as Swati madam has said, that the primary correction cannot be done hysteroscopically, even it cannot be done ultrasound guided. But madam, in our follow-up patients, we have seen that this area reduces back and become a very small isthmosine, or over a period of time, it may not be there. And then later on, you can manage it properly. So right now, I'm just discussing now how I'm going to manage, I'll be managing this one. So the sac has gone completely. Now my suction is at the level of the fundus. I'm gradually sucking it. You can see, of course, this was a live pregnancy having a lot of vascularity. It's going to bleed. So I've already told this patient that once I'm done with this, we can have a beta CG follow-up. It will be showing a downward trend. Plus there will be blood collection because this defect is not going to repair. And this blood will go gradually over a period of 6 weeks to 3 months or maximum 4 months. You don't have to worry. You can just give them a 5-7 days antibiotic coverage. Nothing. Managed quite a number of cases like this. So, but these things you are supposed to explain them in advance, because if you are not explaining them and they get their ultrasound done, it will be showing some blood or some collection at the site of scar. But the beta CG is gradually falling, and over a period of time, everything will go away, and you may not be able to see scar as well in few cases. So this is how the complete evacuation is done. Now this one is going to bleed. We know that this was a live and big pregnancy. I'll be showing you how it was bleeding. And that for that bleeding, we all are gynecologists. We can easily do a massage, suction, evacuation, the massage, and everything will be settled in front of you only. I'll just show you. This is done. So you can see now, immediately after suction evacuation, this patient is bleeding. And I was expecting, because this was a larger one, you can give them gentle massage. Prostrodine may or may not work because there is hardly any myometrium, but within few minutes, the bleeding stops. You wait for the BTCT time and the bleeding is fine. And you can drain this Foley's, you can put a Foley's in the bladder and this can be nicely done. So this is how you can use this section. You know, we all have seen this section. This section has got two cuts and both cuts are lying exactly opposite to each other. So you will have to move your suction in 180 degree to cover your suction area in 360 degree in the uterine cavity. One thing is this. Second is you should know where you are putting, you know, it should go anteriorly, lying at the level of the scar, USG guided, suck it gradually, and you can nicely manage without causing trauma to your uterine areas. So you need to know your instrument and the suction in this case nicely. And this video is showing you how you can control the section. If you have got a foot operated suction machine, you can easily control your suction. MBS syringe with the MBS syringe, you cannot control the pressure. But when you're using pipe connected with your suction machine, you can control the pressure from your machine as well, or by bending your pipe. And this is where you can really do a controlled suction and evacuation, which is completely ultrasound guided. Now here I'm showing you a video of a big scar. You know, this one is, of course, not my domain for today's talk, but I'm going to show you that this is a big pregnancy lying into the area of isthmocele or scar area. The upper cavity is absolutely fine. And so the upper cavity and this pregnancy is exactly lying in a big niche area. With the hysteroscope, it was very difficult for me to, you know, locate and all these things. So I've done it with the hysteroscopy, remove this scarred area. Oh, sorry, remove this pregnancy. And after removing this pregnancy, what I was to show you that when this pregnancy is completely removed, I've taken the help of ultrasound and just wanted to show you that this is how, you know, my hysteroscope was there. It's in the cavity. The area was completely clean. And with when the fluid is entering into the cavity, fine. This is for the suction, and yes. Now you can see my hysteroscope, the same case. My hysteroscope is lying in the cavity, and here the fluid. I'm not pushing the fluid very fast. You can see how much big isthmocele was there, you know, and this was completely filled with the pregnant area. And even with my hysteroscope, I won't be able to see all around this wall. So ultrasound guided, when I've done this thing, I know that the integrity of this scar was maintained. You can remove it hysteroscopically. You can remove it with the help of suction and evacuation, but definitely intraoperative ultrasound will give you a good idea. When I was not using intraoperative ultrasound, I used to do laparoscopic assisted. Sometimes I've done a cystoscopy as well, just to ensure my findings, all like this. Now, this is another video, which is of type 4 scar ectopic. Now, this is, I can say type 4 or some complication. The surgeon has done a DNC and then it was perforated and, you know, gone into the vesico-vaginal pouch, utero-vesical pouch. So it's somewhere around 6 centimeter hematoma, but the beta HCG was gradually falling. I didn't do anything. We have done a conservative management, allow it to, you know, heal it spontaneously, given an antibiotic coverage. These patients, once everything is resolved, they are fine. But these are the patients which you need to keep in the hospital, because if at this time you will do a laparotomy, you might have to progress for a hysterectomy. In such cases, these are all fragile tissue. If these pregnancy, you know, become complicated like this, these are the type 4, or you can say a complicated after DNC. Of course, once you have done management, either hysteroscopy guided or ultrasound guided, beta HCG weekly you should do until it become normal. Have a TBS follow-up, look for any collection and the size of the collection. You will see that the clot is getting fibrosed and everything will be fine in few days. Then you can plan a definitive management. As she said, You cannot do hysteroscopic guided or USG guided. Of course, laparoscopic guided you can do, madam. But what is the problem that we all of us have done a lot of stomosile surgeries. Many times the stomosile is anterior one and sometimes it is enterolateral. It's so much enterolateral that hardly any tissue is remaining. So to exactly locate the lateral recess or the depth of the stomosile on the side, at the time of pregnancy and when you're doing laparoscopic repair, you may not get a complete correction. So you'll have to choose it that whether laparoscope is going to benefit all the time or not. So that decision will be taken by your team with whom you are working and with the help of ultrasound. And then you can say, but by laparoscopy, you cannot be 100% sure that you have done the stomosile correction as well. And then ask these patients to report very early in the next pregnancy. It cannot be like you have done a repair or you have done a suction evacuation that they cannot develop. Of course, in the literature, the reoccurrence at the site of scar is not very much reported. I have seen one beautiful slide which you have shown the comparative of all management. So definitely it is one of the good slide to compare, but not even a single method which is directly you can say that this is the best method to manage the scar ectopic. So that is why in literature there are different method of treatments which are available. Expectant, Indu madam has said no role. Exactly, it has no role because expectant can be for this pregnancy, but this pregnancy, if it grows, is really going to have a problem in their third trimester scar pregnancy related placenta, accreta, increta, and purgata, and the delivery will not be that easy one. Local systematic injections, DNC under USG guided hysteroscope, removal, laparotomy, laparoscopy, vaginal one, and in fact, intervention radiologists, which madam has already discussed, and some of them previously landed up in hysterectomy as well because of the perforation and complication. So there's no such guideline that how you are going to manage. So this is a beautiful webinar you have planned to discuss all the aspects, approach, and choose gradually, but nothing to worry. You know, the way back we used to be very afraid that scar ectopic hair and then how we are going to manage. It is not that complicated one. So the take home for my talk is be innovative. Be innovative in the sense you need to think, you need to try, and this is all of us are doing. And understand and use the technology judiciously, whatever technology you're using, whether it is your suction and evacuation, whether it is your hysteroscope, your pressure system, your cannulas, everything you need to understand and use all these technology judiciously for the betterment of your patients. Never stop learning. Thank you so much. This is my team. On the behalf of my team, I thanks all of you for patience listening, and thank you so much. And I'm